Thank you for coming to our second ground round regarding the Essex Collaborative Behavioral Health Care Project. We're excited to have you here. I'm Evelyn Orozco, and I'm the Program Director for Children's Services here in Newark. And I'm one of the PIs that is working on this project. Along with me, our collaborator is Dr. Dominga Padilla, who is the Medical Director of New Jersey Medical School, and she works with the Division of Adolescent and Young Adolescent Medicine. We're here to share with you some information about our project. We want to share with you some information, but we'd also like to hear from you how we can help you in your practice. So let's begin. Here we go. So what is the hub? It is what we call, those of us that work on this collaboration, it is a partnership with the University of Behavioral Health Care, where I come from, and the New Jersey Medical School, which is Dr. Padilla and her team, and her clinical team. It's funded by the New Jersey Department of Children's Services. This was put together because of the need. We know that many of our services, particularly in Essex County, need some additional services that are not out there. So New Jersey Department of Children's Services actually funded this program for us and with us. The goal of the program is to increase accessibility to mental health services for children and families in Essex County by creating an integrated behavioral approach. This is again providing a collaboration with our medical partners such as yourselves in our medical school and with UBHC Medical Health Services, mental health services. Our objective is to increase the capacity of pediatricians, practitioners who work with families in Essex County and their professional staff to identify behavioral health care and substance abuse challenges that children may present when they come to you and when they come to your practice. We also want to increase your capacity of the pediatricians and family practitioners to treat subacute presentations or disorders. So if a child presents with suicidal serious intent or a plan, that's something that's acute. That's something that you and I'm sure know already, that would be referred immediately to ER, to emergency services. But for subacute, such as if when they present to you in your offices with anxiety or sadness or depression, these are the areas that we would like to collaborate with you. In addition to that, we want to increase the capacity of practitioners and their professional staff to link youth and families to mental health services. All right. What I'd like to do now is sort of stop and take a breath and talk about why this grant was put into place. To look at some of the data that's out there about our youth and some of the challenges that they present with. We know that 20% of all youth currently or in their lifetime will have a diagnosis of some type of mental illness. It may be something ADHD, presenting with some sadness, all the way to something more psychotic or psychosis. We also know that, as reported by the NIMH, that 1 out of 10 youth have a serious emotional disturbance that causes significant challenges so that they can't reach their potential. This disrupts their interactions at school, at home, and in the community. In our office, where we provide mental health services, we see youth who are put out in home instruction because children cannot be maintained in their classrooms because of some of these disruptions, because of some of these mental health behavior or psychiatric illnesses. Lastly, I do want to mention too that parents have reported to CDC, a report that they've done is looked at. Some of the parents discussed that some of the areas that they see more significant with their children are behavior issues, all the way to some conduct disorders, as well as anxiety or depression. And anxiety could be something as simple, not so simple, but let's say that they have some anxiety regarding school. They may be presenting with some sadness. So these are some of the areas that the parents have identified. Looking at more intensive sort of areas they work to see with youth, as reported by the New Jersey Department of Children's Services, they report that 2,731 youth were treated at a hospital for self-injurious behavior, and we see a lot of that with adolescents, especially where they're cutting, also with attempted suicides. I want us to focus also on the age of the child. Look how young we're seeing some of these behaviors, some of these concerns and challenges that our youth are being presented with. In addition to that, we have 269 reported deaths, 269 too many deaths for youth between the ages of 10 and 24. Too many deaths, right? Just something we don't need to see. In addition to that, we see some areas of alcohol abuse, 27% ages, again, 12 to 20, that report drinking alcohol within the last month. Lastly, and this is something that we see a lot in our practice with youth, is the use of illicit drugs. Sampson reports that 170,000 individuals ages 12 and up report that they were dependent or have used some type of illicit drugs within the last year. This is an area that we struggle with. We see a lot of this right here in our own community. So with that said, although we know that there's a lot of need in our society, in our community, especially in Newark, but this grant is specifically for our youth in Essex County, we know that there are a lot of gaps or barriers to services. We know that 25 to 30% of youth need mental health services, yet they don't receive them. The barriers to treatment can be many. Could be money, not just the expense of hiring or getting to an office to see a pediatrician or mental health provider, but the expense of getting there, right? Transportation, child care for the family members. We also know that there are some cultural stigmas to asking for mental health services. Some families believe that whatever happens in the family, there are some issues that maintain the family. The other stigma of my child isn't sick or crazy. So we know there are a lot of barriers that we know and we want to work with. In addition to that, there's a lack of providers, not just mental health providers, but practitioners such as yourselves, psychiatrists who can provide some of these services for our families. Again, thinking about why this grant was developed, and it is to address some of these specific areas. As we saw the data, it does show that early onset was in many of the areas that we saw where children were reported to have some of these disorders. We know it's early onset, so the best practice would be, right, to intervene early on, to provide those services early on. We know, again, that early onset of mental illness is a predictor for low school achievement. The child will not be able to reach his full potential. We also know that those children who are involved in the juvenile justice system or with DICES or BCPMP are also at higher risk for these disorders because they come from many of the traumas and the other areas of risk factors that we see. So with that said, why this grant? Why and how was it put together, and what were the thoughts? The thoughts are that you as practitioners are at the best place to actually identify and to link these youth to services that they need. You are at a unique place where families come to practitioners and pediatricians because they come to you on a regular, consistent basis, mostly. They come to you for wellness visits. They trust you. They have a relationship with you. At that point, they may even come to you for immunizations, or maybe even just to get the child a clearance to go to be involved in football or some type of sports practice. You are in a unique place to provide the linkages and referrals that these youth need. With that said, how could we, Essex HUB, work with you or the practitioners in our community to provide those services? So let's talk specifically about us, the Essex HUB, and how we can collaborate, how we started the collaboration with our partners at the medical school, how we can partner with you in the community when you're working with families and children. Our program provides monthly didactic and case conferences, which you'll be seeing today. Our team is actually going to present some cases, and they're going to walk you through some of the ways that the HUB staff can work with you in providing the best services for your families. The consultation team consists of psychiatrists, psychiatric consultation. We have clinicians, master's level clinicians, one who in particularly is certified with substance abuse counseling and certification. And also we have case managers that can link and refer, and who knows all of the services, or quite a lot of the services that are available that we can link our families to. You can provide the consultation with a psychiatrist in real time. If you have a patient in your office and you're not sure, or the child is presented with some risk factors, you may want to consult. You can certainly pick up the phone and consult with Dr. Power, who's sitting with us here, in real time. And if that's not something you want to do, you can call, and with the consent of the family member, you can send a consent over. And then you can have the family members referred to our team, and they can be brought into the office, and we can do a consultation there. The information will be given right back to the practitioner in less than that day you want information back. It could be given back to you immediately, or it can be done in real time, face-to-face, telemedicine. We also are going to have a web where we're going to be posting information and literature and training on specific disorders. And we want to hear from you what that would look like. What is it that you need from us that we can actually provide and post online for you to be able to review? Again, so the services can be face-to-face, telemedicine, consultation. We can provide a psychiatric evaluation, which will be sent back to you within 2 weeks, if that's what you like, so you can continue treating the family and the youth in your practice. In addition to that, you can continually go on consulting with the pediatric psychiatrist in our site to provide consultation services regarding medication management or just treatment. We can also provide care coordination. So those are the ways that we want to collaborate with you to be able to give you the knowledge and the information and the process of consulting so that we can provide our services to families and youth in Essex County. Now, let's say you have a youth in your office and you're wondering, does this youth need mental health services? How would you assess that? One of the ways that we're asking, and that's part of our grant, is we have screening tools. We have 3 specific screening tools that I'll show you in a few minutes that you can actually have. There's a self-report measure that you can have the youth complete or with a family member to get a better idea of what you need. You can also ask and call our hotline and get consultation with the clinicians or the psychiatrist at real time when the patient is with you. So you find out that the child does need services. Are you able to provide those services? Again, we know that you're in a fast-paced office. You may not have the information or the infrastructure to provide those linkages and referrals. Again, call us. We will be able to, again, provide the consultation services and ongoing consultation even after the first step is started. If at that time you decide that the child needs medication management, you may consult with our psychiatrist to put the child on some type of medication or treatment plan, develop an intervention. Then you can go on a bi-weekly or monthly basis to consult with our psychiatrist. And lastly, can I find the mental health services out there? Again, we have our team here, and we have a panel discussion. We're going to tell you where the resources are currently at. But you don't have to do that. You can just refer the family to us, with the consent, of course, and then we can help and assist you in providing the families with the services they need. The idea is to give you those skills, give you the consultation and the support that you can maintain that family in your practice, but that we can provide you other services that they may need, the linking and referring and sending the youth back to you for treatment. Okay? I'm going to stop here. And, oops, wait a minute, I forgot this one. I guess I just said the coordination and the brief therapeutic services that will continue. I'm going to stop here, and I'm going to turn this over to Deborah Waxberg, who's going to talk to you a little bit about case presence, some of the cases. We have a great clinical team that's going to present some cases. Just to review quickly, these are some of the brief tools that we'll be asking you to complete, but if you decide to work with us, and we're hoping that you will, even if the parent allows and gives a consent and you do not have the time or the structure in your office to complete these screening tools, our staff will be willing to do that for you. Once we get the consent from the parent or the caregiver, we can then work with the family to provide these tools. The most important part, of course, is giving consent so that we can provide these services to the family. All right.
So I'll be presenting the first case. It's a case of a 17-year-old female with a history of hospitalizations for suicidal behavior, presents depressed and non-compliant with her mental health treatment. She refuses to see outpatient psychiatrists as the hospital discharge. She began to cry and reported that she recently broke up with her boyfriend and she has feelings of wanting to hurt herself. So in this situation, what I did is refer her to the emergency room. So we would call the emergency room, let them know about the patient, and then have our nurse escort her to the emergency room. Now, question to the hub, should I have done anything differently with her?
Hi. I think, Dr. Chinese, you did exactly the right thing. Anytime a patient presents with suicidal ideation, particularly with a risk of or a history of suicidal behavior, absolutely send them right to the emergency room. You did the absolute right thing.
So we sometimes get situations where the patient and/or parent refuse to go to the emergency room. What is our action at this point?
Okay, that's a great question. I know a lot of people see that very often. People are resistant to going to the emergency department. So in that case, 911 would have to be called. If someone's in imminent risk and they're presenting with suicidal ideations that are active, you absolutely need to call 911. And at this university, you can call Rutgers Security to escort them over to the emergency room.
So would it change if the child was 18, so now an adult, as far as our management?
No, actually, it would be the same protocol in every situation, regardless of whether or not they're a minor. They're in imminent risk, and we need to protect them.
So sometimes they're not suicidal, but they clearly need help with services. What are the services available to this child?
Absolutely. So that's a great question, and that's where the hub can really step in and help you guys. We'd first, of course, start off with a call to the hub hotline, 7889 for you guys. We would love if you guys could complete the screening tools, but like we said, like Dr. Roscoe mentioned, if you don't have the time, I'm more than happy to do them. We'll help you guys with those. And the most important thing, though, is the consent form. We can't really have a conversation unless you guys sign our consent. That's to protect you and, of course, the patient and family. So at that point, we can initiate case consultation between the psychiatrist, who's on call, like Dr. Powell over here, or myself. And now if this patient, you mentioned, has trouble, refuses to go to outpatient, in this case, it may be a good idea for us to use telemedicine. We have Skype for Business, which is a HIPAA-compliant video conferencing that we can utilize as a team. We know that a lot of practices, doctors' offices, don't have that technology, but we would kind of recommend maybe you guys thinking about how to implement that into your practice. Some people have talked about getting webcams in their consultation rooms. It's food for thought, what we could do. Or we can just do it over the phone. In addition, we could actually call the family ourselves and set up an appointment for the family to come over to us. And that won't take very much time at all. When we get the referral, we'll reach out to the family right away and then let you guys know when we're able to make contact. At that time, we can provide brief psychotherapy and medication management if indicated in collaboration with the pediatrician, with you guys. If you guys feel comfortable after consultation with a psychiatrist providing or prescribing some psychotropic medication, we would collaborate with you and work with that. But if you're uncomfortable, we can provide that in the interim until you feel a little bit more comfortable. The idea would be to collaborate and then have you guys kind of take over. In addition, to providing the brief psychotherapy, we can link the family to services that we think would be beneficial. We may link the family to Perform Care to initiate services through Partnership for Children of Essex, which is CMO, especially due to the history of suicidal ideation. So I was wondering if Vanessa, would you mind kind of chatting about that a little bit?
Sure. So, the Care Management Organization, CMO, is part of the Children's System of Care. And through the Children's System of Care, you can get access to a variety of programs. So the Care Management Organization is one of those programs. And basically, it's a call into the hub, which we have as the Central System Administrator, called Perform Care. That's our hub. And basically, with consent from the guardian, information will be provided, and based on that clinical information, the youth can be referred into our program, which provides intensive care management for that youth. So that means that we have a care manager that's going into the home, is working directly with that family, is working with any therapist that may be involved already, any pediatrician, any school personnel, nurse, psychiatrist, and we're there to coordinate the care that's happening for that youth and monitor that care over a length of time. It could be 6 months, it could be 12 months, it could be 18 months. It's based on the need of that child and the family at that time. So there's always an overseeing of the plan. We're collaborating with the team around us. If things are escalating, we'll make sure to refer the youth into the right treatment. As things stabilize, we will transition out. So we work with youth that not only have mental health, behavioral health, but also any developmental disability. We will assist the family if that's part of what's the presentation. Maybe it's looking like it's mental health, but there might be another factor. We'll work with the family in that. And we also work with youth that are struggling with substance use or abuse and getting them into treatment. And then from that point, getting them to the next step. Because we know a lot of times youth are using substances to maybe, cope with other stuff that's going on, which is typically mental health. So once we treat that piece, we can kind of oversee. So our program, we're going into the home, we're meeting with the families, and we're staying in connection and just keeping that team together. So it's pretty intensive. But in order to get into that, we would collaborate with Perform Care, and then we would take over from there. And we service youth as young as 5 up until their 21st birthday. So pretty long term.
What is your capacity, and can you accommodate all comers? Are there insurance requirements?
Nope. So everything, any time a family is referred into Perform Care, and then if they're recommended for care management services, there's no cost to the family, and there's no need to have active coverage. We work with the family to obtain appropriate coverage if needed. So if the family has no insurance, we assist them in completing applications to see what they do qualify for. But if they have a private insurance, we generate a temporary Medicaid number so that our services are always covered. So no cost to the family, and there's really no exclusionary criteria. So we work with undocumented families, we work with folks while they might be like a lapse in the Medicaid. Typical services that we're providing that are pretty common are intensive in-home, where the therapist is going into the home. Dr. Roscoe had talked about some barriers, often maybe transportation, childcare. So our therapists are able to go into the home and work with the family with the goal of connecting them into the community once we achieve stabilization.
You do a catchment area, because there used to be a barrier for us here. Is it all of Essex County?
It's all of Essex. And there's a care management organization in every county in New Jersey. So let's say we have a family that moves, we then make sure we connect them to the care management organization in that county so there's no lapse in service. And again, free, it's a voluntary service, but it's free to the families and the youth, and there's no drop because it's throughout the state of New Jersey.
Thank you, Vanessa.
The next case that we're going to present is an example of the kind of patient that we see almost every day in primary care, where parents come in often with complaints of either behavioral problems or school problems, and often a combination of both. And they really like to know why the child's having the problems, what they can do about it, and more importantly, where they can go to get the services to help their child. So it's really involving a multidisciplinary approach. So this case was an example of a 7-year-old boy who was coming into our office for the first time, and the mother was complaining of aggressive behaviors both at home and at school. The child finished first grade and went into second grade, but the mother reports that he really did poorly, and although he passed his classes, she wasn't happy with his performance and didn't feel that he was working up to his potential. He never had been evaluated at school for any services and wasn't receiving extra help in the school. Going through the history, the mother also felt that he really never spoke as well as her other children, and although she had asked for evaluation in the past, was never referred for speech evaluation by the previous doctor. She notes that the child doesn't enjoy being with other children and is very particular about routines and doesn't like deviations from his routines. In the office, he really didn't engage much in conversation with me, and watching him with his mother, he really didn't engage much with her in terms of interaction. So my initial considerations, obviously, first of all, is the child autistic and wasn't picked up earlier on, but we also worry about maybe learning problems as the basis for the behavioral problems and interacts, or mental health problems. And it can be any of those or a combination of those. And it's often hard to know what the primary diagnosis is. So in this kind of a case, what I would usually do is try to help the mother begin to seek services for the child and arrange some follow-up. And so it's a lot to ask her to do, and we have to go through several things. So first of all, we would refer her to child development for an autism evaluation, so we'd ask her to call for that. I'd encourage her to seek mental health evaluation. So we have the psych access number that we call for our Medicaid patients, and they can call and ask for an appointment to be evaluated, either for individual therapy for the child or for family therapy to help the mother with some parenting skills and how to deal with these behaviors at home. And I'd also ask her to go to the school and ask for a child study team evaluation, because that's really where many of the services related to school performance are going to have to take place. And even if there are recommendations from the specialist or from the mental health provider, the child study team needs to generate an educational plan for the child in order for those services to be given. And so we're going to be doing all of those things, have the mother follow up in a month to kind of make sure that things have happened, or at least beginning to happen. And I usually would send her out then with the mobile crisis number in a case like this, in case the behaviors get unmanageable or that she feels there's some kind of a threat, that she has someone to call in that case. So my question for the team really is there something that you could offer to help streamline this and to help follow up with these patients to make sure that these things happen kind of appropriately and timely?
Yeah, I mean, doctor, you did so much work for this family. You referred to multiple places, you connected to multiple places. The cool thing about the hub is that we could actually do that for you guys simply by calling 7889. And, the process, the consent forms, the screening tools, we could do that for you. So you could spend the time in other areas. So what we would do, clearly we need some clarification in the diagnosis here. The first thought I'm sure everyone had was autism spectrum, but I think that there could be other things going on too, and that's when the psychiatric evaluation would be helpful. Consultation also with myself, the rest of the team, the other psychiatrists, that would all be very helpful. Now, if this kid doesn't like straying from routine, again, maybe telehealth could be helpful so that they can have a conversation from the safety and security of a place that they're already really comfortable in. Or we can outreach the family and have them come to us. And in that case, we can, clarify diagnosis, provide some brief psychotherapy and medication management if that's indicated as well, as we spoke about previously. And then we can also support your referral over to a developmental pediatrician to...
I couldn't do that.
Oh, hello.
Let's try again.
To seek testing for potential autism diagnosis, referring to Partnership for Children with Ms. Vanessa Matos to assist with autism spectrum services that you guys offer, and also any outpatient therapy. And I was going to ask Dr. Aurora, what does Rutgers offer for outpatient and those types of treatments?
So in child and adolescent outpatient services, which is right next door over in the Behavioral Health Science Building on C level, we see children ages 5 up to 18, and occasionally even a little older than 18. And then we can also transition them out to adult services. We provide individual therapy, family therapy. We actually have a strong emphasis on family therapy and working with the caregivers. We can also provide psychiatric treatment, as well as psychological testing. So potentially for this child, it sounds like he could benefit from psychological testing to determine if it is autism spectrum or if it's more of a learning problem. So we could definitely help in those areas.
Awesome. So sometimes there's a waiting list for the outpatient services, and the cool thing is that we can provide the brief treatment and also kind of fast track the process for the family. So they don't need to have that waiting time when nothing's really getting done. And you, doctor, would receive a written report from us within 2 weeks. You would know what was going on. We'd probably call you and let you know once we've made contact with the family and kind of devised a plan, but you would receive a report from us pretty quickly.
That's one of the things that is often lacking, is that feedback, especially from mental health, to know what's going on, so we can follow up with them.
Awesome.
So one of our other concerns with a case like this also would be possible abuse or neglect as the cause for the child's behavior. You mentioned the ACE, the Adverse Childhood Experience Questionnaire, as one of the tools that we use that will elicit some risk factors or yes/no questions to potential or actual abuse in the family. So if we uncovered something, obviously we'd call DCPP, but is there a role for HUB in terms of that line of questioning, in terms of helping us decide whether a call should be made or not, and then what kind of follow-up could happen with DCPP related to cases like that?
That's an awesome awesome question. It's always kind of concerning when you hear a kid, of course, report something like that, and also knowing what to do. The ACE questionnaire is pretty explicit. It will ask, like, have you been abused or neglected? And if the child says yes, that would be, because you're a mandated reporter, you'd have to make a referral to DCP&P. If there's a suspicion, but not really founded, you can call us, call the hub, and kind of let us know your concerns, and then we can do some follow-up and kind of dig into what's been going on. But luckily, the ACE questionnaire asks those questions, so you're assessing for the safety of the patient, which is so important. That's the predominant issue and need. And then we can kind of work through from there, and even follow up with DCP&P if a referral is made.
Okay, so this next case is a 13-year-old male who presented to the clinic with a history of hyperactivity and impulsivity in the classroom, as was reported by the teacher. So during the interview with the parent, he was sitting in the room, as some teenagers typically do. He was, very fidgety, very jittery. He appeared restless, and he was bored, shaking his legs while texting on his cell phone. And he kept interjecting, when I was asking the mother about his academic performance, but just very angrily. So the mother reports that from 3rd grade to 6th grade, he was an average student and had a lot of help from his teachers, such as extra time for tests, smaller classroom sizes, and the teachers also helped him by substituting assignments for easier ones in order for him to pass his classes. So since he started middle school, the mother reports that he has experienced a lot of difficulties in school, focusing, forgetfulness, anxious behavior, and some angry outbursts in the class that led to his poor academic performance. So the first thing what I did was I told the mother if she could obtain from the school his progress report, his report card, and if he has an IEP. And the next step I would do would refer him to behavioral services and also neurology to make sure nothing else, is going on. But with that said, the mother did admit that he was diagnosed with ADHD when he was much younger, but she did admit also that she hasn't been compliant with the appointments because insurance issues, and then also she was very reluctant for medication therapy. So how else could the hub help me for ADHD?
Awesome. Just like Dr. Schwab, who did a ton of work with the family, again, stuff that the hub could take care of for you guys. Just give us a call. When in doubt, call the hub. So yeah, we could definitely work through that with that family. Again, further assessments will be needed to determine what's going on with the client, with the patient. First thought, probably ADHD, especially with the past diagnosis, but we know that it could also suggest trauma or ODD or bipolar disorder or depression or 1,000 other different things. So the hub can, through further consultation and assessment, we can kind of help you clarify that a little bit more. We could assess for appropriateness for ongoing treatment through all the services that Dr. Aurora mentioned. Provide linkages to perform care. I know a lot of this is kind of repetitive, but I want you guys to really know what we can do for you guys. Medication, if it's indicated for mood, and if the family does not want medication, we can also provide behavior modification as well in the interim. Crisis center, we can make a referral over there if the child had a really difficult day in school and may need a clearance in order to return back from school. And we can also help support you with the client getting over to neurology or any other appointments. We can help you identify the barriers and maybe link them to some supports.
Okay. Now, initially when I saw him, I did do a head screening, and he denied any drug use, suicidal ideation, or any risky behavior. But then as I got to know him, so subsequent, other visits, he did finally admit that he did use marijuana. Now, he said that it was a way for him to relax and to kind of self-medicate himself because he felt very frustrated in school. So he did admit to using the marijuana. But I suspected he probably used it more frequently than he was letting on. So my question to you is, how would you, get around confidentiality issues? I kind of want to let the mother know my concerns, but at the same time, how do we get around confidentiality? Because technically, we're really not supposed to, let the parent know.
Absolutely, and just so you guys know, there is a withdrawal for marijuana use. It can make you irritable, it can make you anxious, angry. So just because the kid is 13 and just because they have a past ADHD diagnosis doesn't mean there's not a co-occurring substance use disorder going on. So just because they're young, do not avoid those questions. I've worked with kids as young as 7 using a lot of stuff. So in terms of consent, that's definitely a really common issue that people encounter. Substance use information is actually protected just like STD information and sexual behaviors. So it's very specialized and it's protected under HIPAA. So typically you only share with the guardian against the client's wishes if there's, again, an imminent risk. That's when you're breaking confidentiality in terms of other things as well. If there's an imminent risk. Probably occasional marijuana use, obviously it's not healthy for the client, but it's not going to be an imminent risk. But that's a conversation that you need to have and kind of assess. But just so you guys know, if a kid doesn't want to tell their parent, there's probably a reason for that, and that doesn't necessarily have to be your job. The hub can help you with that. Typically, research has kind of shown that disclosure to parents can actually hinder a minor's treatment and may lead to punishment or abuse. You really have to think, why do they not want mom and dad to know, or guardian? Many minors actually won't even seek treatment for their substance use disorders if they're unable to get it confidentially. So again, only share if there's imminent risk. Luckily, our consent form for the hub actually has a section that permits the client, the doctor, to disclose substance use information to us. So whatever reasons why they don't want to share, we'll work through that with the family and ultimately hopefully get the parent on board because that's essential for recovery.
Okay. And my last question, in terms of collaboration with the school, do you guys work with the school to help this child that has ADHD as well?
Yeah, so the idea would be to bring the family in hopefully and we can get a consent form signed and bring out to the school to get some collaboration, definitely.
So the case I'm presenting is a 16-year-old who comes into the clinic and the request is they need a refill for hormones, all right? So preferred pronouns in this case are he, him, his. He's new to the practice, recently from Pennsylvania. He's been on testosterone about a year. He attempted suicide, so of significance is that he attempted suicide at about 12 years old in conjunction with Minarchy. This led to linkage to mental health services, and that was because of let's leave it at that. So there's linkage to mental health services at that time, and just to keep in mind that there's the current transgender health guidelines actually require continual follow-up with a psychotherapist, so it's counseling of sorts. His therapist, and this is again only a year ago, right, because he was in treatment with a counselor, but not on hormones, up until a year ago, where the therapist then wrote the letter in support of diagnosis of gender dysphoria, and then mental health clearance for initiation of the cross-gender hormonal therapy was provided. And then the chronologist was identified, and they initiated hormonal treatment to block puberty. So it's been about 11 months since the individual has not had menses. Due to relocation, he's not had any mental health counseling for about 2 months. So now he's in New Jersey, he's asking for a refill, and it's been about 2 months that he hasn't been really connected. He's been frustrated, anxious, angry, because he's been desperately trying to seek services similar to what he had in Pennsylvania and was not successful. So somehow he found the Hedrick Martin Institute downtown Newark, where they provide psychosocial services to LGBTQ identified youth. They knew about us because we work closely with them in the adolescent medicine clinic. So they referred that individual to the Division of Adolescent and Young Adult Medicine because they knew that we had some familiarity with and some knowledge with regards to working with this population. So the individual came, again, he was very frustrated, anxious, angry. He came with his mom, and his mom was very supportive, very impressive. Whatever she had to do, she was willing to do for him. What was concerning to me is that he was extremely frustrated, anxious, and he stated that he doesn't know what he will do if he gets his period. and he had a positive PHQ-9 as well. So he doesn't have a refill. It's been 2 months since having any testosterone, and he's been frustrated by not getting access to it. So what did I do in that situation? So again, with my limited knowledge and information, because I require training in this area as well, we're fortunate enough now to have Dr. Benzionov that comes with that information. But at this time, she was not with the division. So the individual came. I reached out to the Pennsylvania team to try to get the information and get the real nuts and bolts of what really was occurring there and what can be continued in New Jersey. And what I found was that there was truly, I just verified that there was a high risk for suicidality in this individual if we don't do something. So again, my primary focus was trying to get that refill. Even if it's just a temporary one-time refill, to have a little bit of time to try to make some of those linkages once they're here. So I went forward to do that. In calling the insurance company refused to provide the refill, pay for the refill for testosterone, because the individual, again, because of the guidelines put forth for transgender health guidelines, you're supposed to be in mental health services or counseling, and this patient was not. So they didn't want to refill that prescription. So I pleaded my case with them, expressed my concern about the issue of suicidality. They worked with me. We were able to, I had to provide a letter to the insurance company saying that I would provide temporary counseling and very close observation of the individual, and that they would provide me a one-time refill, and that would give me enough time to try to link the individual. So that was fine, so we went ahead and we started the individual on testosterone. As I pursued, and I had the individual as well continue to seek a connection or linkage, and we were unsuccessful. So when I went to refill it the second time, it was declined. The individual was very angry, very upset. They fell out of care, so they're no longer in service. I called the mother, the child, and I can't get through to them, so I'm not sure where they are at this point. So my plea to the hub, what can be done to prevent cases like that they fall out of care because of the difficulty of linking them to services, in particular for individuals who self-identify as transgender or are trans, because we have multiple situations like this right now. We have individuals that we're having difficulty linking to mental health services, and Dr. Benzionov is actually managing that within our division.
Yeah, absolutely. That's definitely something we need to talk about. First and foremost, as always, if a client or patient is actively suicidal, at risk to harm to self, absolutely right away to the emergency department. Then you could, if that's not the case, if the patient is stable and denying that, you could definitely call the hub. We may assist you in safety planning if and when that individual does begin menstruating. We don't really know what's going to be the case. But then we can link the family to Perform Care, who can actually link from Perform Care to mobile response. So I'm wondering if Ms. Louise can talk about that.
Actually, any of the cases already mentioned could potentially be referred to mobile response as well. We're a 24-hour, 7-day-a-week program funded by the Children's System of Care. Just like CMO, we go to the homes. So what's unique about us is that we respond to the homes within an hour of the parent calling us. So again, we're 24/7, so if they call at 3 a.m., and in this case where the child's currently missing, if they were to call us, if the child were to return at that point, and they call us at 3 a.m., we'll be there within an hour. Like I said, 24 hours, 7 days a week. We service children as young as 2 years old up to the age of 21. And what we do is we do what's called a crisis assessment tool, and based on the ratings of the assessment tool, we then link the child to appropriate services, whether it be outpatient services, in-home services, mentoring, behavioral assistance, partials. It runs the gamut. We also do concrete services like linking them to recreational activities or support groups. So someone like this child would probably have benefited from a support group as well. We also, within the first 72 hours, keep contact with the family on a daily basis. And then that time, like I said, we come up with a disposition to refer them to more appropriate services. We then stay involved with them up to 8 weeks to make sure that they are fully linked before we transition them to any other kind of services.
That's awesome. Yeah, that's fabulous. And because we're all in the same building, we can follow up. We can communicate with one another. And in addition, if mobile response isn't involved, on occasion, HUB can do home visits to kind of check in with the family, especially if they've fallen out of care, just to make sure, because that's concerning and that's also really upsetting. So we can, while they're waiting for longer term services in mental health, we can provide that psychotherapy. And then while we're doing that, we have Cynthia, who's really skilled at linking clients throughout services throughout Essex.
Sorry, can I add something that
Oh,
actually
yeah.
mentioned before? We will actually also respond to your offices, so we don't only just go to the child's home. Wherever the child's at, we'll go to the schools, offices, hospitals, wherever the child's physically at within Essex County.
Awesome. Thanks for adding that. That's awesome.
So what services are available specifically for those that are LGBTQ identified and, they have their certain health disparities that are related to that particular group? What does the HUB have in place? Because this is something that we're seeing more and more of, and I'm not sure if just institutions in general. I know that the Division of Adolescent and Young Adult Medicine doing what we can with regards to training and trying to get that out there with regards to just having a higher level of comfort with managing that those individuals. But how can the HUB help with that particular population? Do you have anything in place?
So there are resources out there. One in particular is the RAIN Foundation, which caters to youth that are near homelessness. There's the African American Office of Gay Concerns in Newark, that's located in Newark. That does HIV testing in addition to food support. There's also a community center for LGBTQ, which has 2 licensed clinical social workers there. And then I was able to make contact with a private provider who did accept Medicaid in West Orange, who specialized in treating children with LGBTQ issues. So, there are resources out there. It's just, my job to kind of find them. And just in case you're wondering, NJ211 is like a fabulous place to go to looking for resources. They have an entire database of every single concern that you may have. There's a resource for it, just in case you want to know.
That's awesome. Yeah, so you don't want to do that. That's what the HUB is for. We can do that for you. You have Cynthia.
Oh yeah, it's definitely tedious, but.
So thank you for that information, and I'll call Deborah back up to the podium.
So some important things to remember, Essex HUB is here for consultation, resources, referrals, trainings. We will be having a website up and running shortly, and we will be posting some trainings there, so there'll be a web-based information for you to access. The one thing I want you to remember is our phone number. For in-house, it's 27889, and you can call with some questions or for consultations if you're unsure. We are really here to meet your needs. We want to hear from you what you need for future trainings on, and what we can really help to build the capacity for your practices.